Okay, let's talk about the second part of MRI. We talked this morning about the uses on the CNS, but there are funner ways to use MRI. This actually, one of the things was brought up yesterday when we talked about how do you image a pregnant person who might have a PE. Somebody mentioned the idea of using MR. The other thing that pregnant patients will do that make our jobs difficult is get appendicitis. And you don't really want to radiate somebody who might have appendicitis as well. Can you use MR for appendicitis in pregnant women? That's abstracts 1 and 2. I'll tell you the bottom line on this. It is a promising tool, but it's not quite ready for prime time with appendicitis. These are 2 small studies, 51 pregnant patients in one of them. The other one was 23 pregnant patients. The first paper looked pretty good. When they were negatives, they were true negatives. It looked pretty good. When they were true positives, they were positives, they were true positives. It was 4 true positives, 44 true negatives, and inconclusive in 3, which led you to think, okay, well, there's some other study you're going to have to do. But for the most part, it was pretty good. The problem is abstract number 2, it actually flat out missed 25% of what turned out to be true APIs in these patients. So it's at this point not totally ready for prime time, but is an option to consider. I know that this is, my husband just had a case like this, and he's an ER doc as well, where he talked to the radiologist. They said, let's go ahead and give this a try. We'll go ahead and look for an appendicitis and see. It was there, and it was a real API. So it is something to consider. I would talk to your radiologist and see how comfortable they are dealing with appendicitis in a pregnant woman with MR. How comfortable are they in reading the study? I know that it's not perfect, but the nice thing about it is it's no ionizing radiation that you have to give to try to make that diagnosis. Yeah.
Is there any data on magnetic fields and field development?
Fascinating. Is there data on magnetic fields and fetal development? Yes and no. Not a lot of data. You'd think that with this technology out there, they would have radiated 8 million pregnant rats and see if something happened, and they didn't. There's not a lot of data out there, and we'll talk about it at the end. It is, despite the fact that there's this study, these studies of pregnant women with appendicitis, and there's also pregnant women and PE, there's separate PE data. It's done. It's being done. It is a relative contraindication to do MR in someone who's pregnant. So the radiology sphere is sort of talking out both sides of its mouth on this one. I'm not aware, and there isn't any data that I know of published that says it does bad things to developing babies. So I'm not aware of it. We certainly know ionizing radiation does. So I think if you're going to weigh the 2 options and you're making a choice between one or the other, I think you have a very good logic to say, I'd rather MR somebody now, knowing the limitations of the study for what you're looking for. But I think, do we know if it's completely safe? No. And the radiology literature says it's a relative contraindication. So they basically covered their heinies both directions. How about for venous thromboembolic disease? How about for DVT? Can you substitute MR for imaging studies of the lower extremities? Basically looking for DVT. I'll cut to the chase. It is similar to ultrasound from the groin down, meaning that it's fine at proximal DVTs, but about the same actually as ultrasound. Ultrasound is really good for proximal DVTs. It's not so great at distal DVTs, and it misses about the same proportion of calf DVTs as does ultrasound. So it's about right now it looks the same from the groin down. Where it is hands down better than ultrasound is in pelvic DVT. It is significantly better in pelvic DVT. So if you're really hunting for that DVT that may actually be proximal, may actually even track up into the belly, MR is a significantly better study. By the way, it is a vascular structure you're looking for. So it's a gadolinium you're requiring study. You have to give the contrast agent. We'll talk about gadolinium at the end of this because gadolinium has its own problems, but it is a better study to do for pelvic DVT. Otherwise, it's the same as ultrasound for anything distal to that. How about in PE then? If you go to the abstracts 6 and 7, looking at it for PE, the benefits of MR over CT is no ionizing radiation to the structures, okay, and no contrast, iodinated contrast. You still have to have gadolinium, but gadolinium is not iodinated, so it's not like a CT angio that uses contrast. It doesn't have ionizing radiation, and it ends up being about the same at picking up PE as CT angio. So as far as its ability to see the PEs, it picks up the central ones just fine, so does CT angio. Where it starts to fall off is at the 2 branch point beyond, which is the same place where CT falls off. So the bottom line, honestly, is that for PE, it is probably equivalent in sensitivity and specificity as CT angio. No ionizing radiation, no contrast. Okay, no iodinated contrast. So you have some benefits to it for sure. And this is something that for the pregnant person is something to consider as an alternative if you have access to MRI. So for PE, it's probably the same as CT angio with two real upsides, which is no ionizing radiation and no iodinated contrast. So that's kind of helpful. Okay, that's the appendicitis in pregnancy, DVT, PE. Let's switch entirely to orthopedics. This is a technology that has been used hugely in orthopedics. Let's see whether we should be doing any of this jazz in the emergency setting. Let's talk about rotator cuff tears. Extraordinarily common. Two groups of people get, well, actually three, get rotator cuff tears. The jock, okay, we've all seen the pitcher whose career is just blown out of the water by a rotator cuff injury. The overuse syndrome, particularly people who load things, that are putting things up over their heads all the time, load things, that's a rotator cuff injury waiting to happen. And as you age, your shoulder is used so much in your lifetime that as you age, rotator cuff injuries, by the time you hit 50, and definitely by the time you hit 60, the likelihood of a rotator cuff injury skyrockets, just skyrockets. From just daily life, it's a problem because your shoulder's used so much. If you think about the shoulder, I think orthopedics is, I love our version of ortho, the upfront acute injury, fix it or not, or diagnose it. I love what we do for orthopedics in the ER. I'm not the sort of erector set person in the OR kind of person. I like the ER version of ortho. I think what we get to do is the fun stuff. I find joints absolutely amazingly fascinating. And the shoulder is an engineering miracle. It is a remarkable structure. It is a ball in a socket that actually comes out of several different bones that come together and a bunch of ligaments that let it hang in space such that you can think of what you can do with your arm. It is unbelievable what this structure can do. It is an engineering miracle. If you've ever had a chance to go see those plastinated bodies, those body worlds kind of exhibits, it is well worth it just to see how the hand works and just to see how the joints work. It is really worth seeing. They have some amazing dissections of how the shoulder's put together. It is no surprise. What amazes me about the shoulder is that it isn't hurt more often. What it is expected to do is remarkable. It is an engineering feat. It is amazing. Should we be doing MRs for rotator cuff injuries? I'll tell you the answer to this is, for our purposes, no. It does help. MR helps the orthopedist down the line determine if there's anything they need to do surgically. But for us to pick up an injury, we are just as good at doing a good exam as an MR is at picking up the injury. The key is to know the good exam. What's in the rotator cuff? I mean, this is going back to sort of med school anatomy lessons. What's in there? It's four things. Sits is the mnemonic. So what are those four things? Supraspinatus, infraspinatus, teres minor, subscapularis. The most commonly injured is S number 1, okay, which is supraspinatus. That is most commonly injured of those structures. You need to know how to examine somebody who has a potential rotator cuff injury, and it is super easy. There are two ways you can test for supraspinatus injury. The most sort of specific but least sensitive of those is the drop test. Okay, your shoulder getting up to here is rotator cuff. Getting from here to here is deltoid. What you're going to do to see, and it's the supraspinatus that gets you here. Okay, it's the deltoid that gets you here. What you want to do to check for a complete tear of the supraspinatus is you're going to take the person and you're going to passively raise them up over 90 degrees and then have them hold it there. That is being held by the deltoid. Then you slowly have them lower. Put your hand underneath to catch them, because if it's a complete, what's going to happen is they're going to hit 90 degrees and it's going to do this. Because now they're supposed to be recruiting the supraspinatus. It's not there. Okay, so it is very, very specific. If they do this and then it drops, that is a supraspinatus injury, flat out. Problem is that sensitivity is only about 20%. And it usually is a complete tear that will do that for them. A more sensitive test for a supraspinatus injury is to have them basically take their elbow, or take their arm, out to about 45 degrees, and then in the front about 30 degrees, thumb down. Then you push down on their arm. They basically are trying to push up against you pushing down. That recruits the supraspinatus alone. If they have tenderness or pain on that, or they cannot hold it against your resistance, that's a supraspinatus injury. Now the IT, the infraspinatus and the teres minor, that's external rotation. And the way you test for that is have them bend their elbow at 90 degrees and externally rotate against resistance. If they can't do that, they have the infraspinatus or the teres minor. Subscapularis allows you to completely internally rotate your shoulder, and the way to test for that is the lift-off test. See if they can actually lift their arm off their back there. You do those maneuvers, you've tested all of the bits of the rotator cuff. You in your testing are more accurate than than MRI scanning is in picking up the injury, at least acutely. So we're just as good as MR as far as the shoulder is concerned, and the shoulder is fabulous. It's an amazing, amazing joint. I think it's fabulous. Plus, there's nothing funner than a shoulder relocation. If you're having a bad day, a shoulder relocation just kind of makes your day. You know you can fix it, you put it back in, you feel like you're actually doing something. It's great. I love shoulders. How about elbows? We all know to look for the fat pad sign for radial head injury. If you get to abstract number 9, we're looking at sort of MRs and elbows. Should we be doing MRs for radial head fractures? We know that they're hard to see. Okay, all we have is looking at the posterior fat pad sign. Look for fat behind the elbow at the back part of the elbow joint on a lateral of the elbow. Looking for that. Is MR necessary to pick it up? It doesn't necessarily see the fractures that much better than a plain film. It definitely picks up the fat pad sign the same. MR isn't that much more sensitive. And I'll tell you the most sensitive thing you can do to diagnose radial head injuries is put the patient at 90 degrees in a completely relaxed state, have them supinate and pronate their forearm. This is all they have to do. The only thing moving when you do this is you're rotating the radial head and the annular ring. If there's a fracture, it hurts like a son of a gun to do this. You can palpate if you want to as well, but this is plenty. That will hurt them with a radial head injury. Look for that fat pad sign. MR scanning acutely is not any more increased yield. Definitely not worth going to. So your exam plus a lateral film is just fine on that. Say again? Actually, the tuning forks are very helpful with scaphoid injuries, and they can be helpful with radial head injuries as well. The tuning fork, especially the big heavy one that really has a lot of vibration, if you put it over a scaphoid fracture, there's some good papers that were published on this. It hurts like crazy if you have a scaphoid fracture by vibrating the bone. So tuning forks are an option as well. Speaking of scaphoid fractures, there's a couple of papers in here, abstracts 10 and 11, looking, should you be using that for scaphoid fractures? We know the problem with scaphoid fractures is about 20 to 30% don't show on first film. Okay? In fact, if it shows on first film, it's usually a pretty bad fracture. And the issue for us is we want to diagnose these injuries because the blood supply is backwards. Okay, the blood supply ends up going distal to proximal through the length of the scaphoid bone, and if you crack it through and affect the blood supply, you get avascular necrosis of the proximal piece. And that proximal piece is the fulcrum upon which all of your wrist action works. It's a really important bone. We all know this test in the snuff box, and by the way, the snuff box technically is pushing not proximally. If you look at your own snuff box and you push proximally, that's your distal radius. Okay, that's not your scaphoid. Your scaphoid is deep in the snuff box, and you can actually feel your own scaphoid. Okay, if you take your snuff box and you basically ulnarly and radially deviate your wrist, you'll feel your scaphoid pop out as you ulnarly deviate. That's the snuff box. The bottom line is acute MRing isn't a thing to go for on this. Can you diagnose more of them? Not really, actually, but it is the absolute test of choice in follow-up. So if you're seeing that person that day 1 that had snuff box tenderness, plain film was negative, you decided to go ahead and immobilize, send them back. They come back like you asked them to, and they're still tender in their snuff box. You can try a plain film, but the plain films still don't pick up all of the injuries. MR absolutely does, and it is one place where it definitely has a role in follow-up of possible scaphoid fractures. How about hips in kids? We all know that the limping child poses a huge series of potential problems for us. Is an MR indicated in evaluating a limping kid? It is great for picking up osteo, soft tissue infection, and abscesses. It's a gadolinium requiring study to do that, and it is no ionizing radiation to the developing gonads of a kid. So if you have access to 24/7 MR, you have the limping kid, you're worried about something bad in that hip joint, go for it. This is a very good study in that particular patient population. How about the 87-year-old who slips in her kitchen, comes in complaining of knee pain? You examine her. What you find on exam is actually hip pain when you go to examine her. So you get your hip films, and they're negative. But she won't walk. Your knee exam is fine. Her hips, what's the problem? Try to get her up, she won't walk. What's the problem here? Why won't she walk? Occult hip fracture. Absolutely can occur. The reason it's occult often is because they're so osteoporotic you can't even see it if it's there. There just isn't enough bone to show you Gardner's lines getting interrupted, so you can't see it. What is the best imaging study at that point? I'll tell you flat out. Bone scan doesn't work. CT maybe, although MR is even better. For the acute occult hip fracture, MR and CT are close. MR is a little better. The ionizing radiation issue isn't as much of a problem in somebody who's 87 or 65 or old. Over 50, it's sort of a light me up thing. Have at it, radiate me all you want to, because I'm not going to live long enough to get cancer. It's probably less of an issue for ionizing radiation, CT or MR, but you don't want to send that person home. Occult hip fractures absolutely occur. There's absolutely no question about it. And by the way, one thing about this is it is important to make the diagnosis sooner than later. It isn't necessarily something where you want to say, well, we'll send grandma home in a wheelchair, let her stay at some bed rest for a couple days. If she's still having pain, we'll image her later. It turns out the orthopedists do something different if that fracture is there. Even if it's an occult fracture, they will pin them. They'll pin them and get them up as soon as possible because that absolutely changes their long-term prognosis after hip fracture. The sooner you operate and the sooner they're up and about, the better they do by far. By far, you want them up. You want them in a chair 12 hours after that fracture has been fixed. And you want to know that fracture is there. So it is worth imaging acutely. The person who has hip pain has fallen and you can't find anything on plain film. Now, how about your knee? I'm sure a lot of us in this room have had knee injuries. I've had 2 knee surgeries, thank you very much. Is MR good for meniscal tears? So you have an acute knee injury. Is MR better than exam for an acute meniscal injury? The answer is no, but. They say physical exam is more accurate than MRI in predicting the need for surgery for meniscal tear from acute meniscal injury. Does anything bug you about that? You can't. Who in God's earth can get a careful knee exam in an acutely traumatized knee? They call it an internal derangement of the knee, which is, I picture some psychotic person running around in that knee somehow. It's an internally deranged knee. They have an internal derangement of the knee. You see them, they've got 35 cc's of blood in there. It hurts like a son of a gun. You do all those maneuvers on those patients, it never works. These studies were done in orthopedists' offices, where the knee has had time to chill out, calm down. It's less acutely inflamed and tender. And they can actually do a good physical exam, checking for the click, checking for the medial joint line tenderness. They can do a better exam. And it does turn out that a good exam is more predictive of the need to have your meniscus fixed than is a positive tear on MR, which makes some sense. There are a whole lot of people walking around there with tears of their knees. They don't need operations. But if you have a physical exam that shows that you have dysfunction or significant injury, absolutely, that is much better. A bunch of papers in here on that. So say you're now 65 and you're hiking up here, it's beautiful, and the knees are just kind of crunchy and bugging you, and end of the day, you're becoming an ibuprofen addict because you just kind of hurts, and you think maybe you just need a little clean out in there. Just do a scope and just do a little cleanup in there. That's got to be the problem. Can an MR be used in that situation to determine whether or not you need that scope? The answer is absolutely yes. If that knee is crunching and crackling and giving you trouble when you're hiking up and down all over the place, and they do an MR and it shows no significant internal abnormalities, they don't need to go in there because it won't do any good. Now, if it's positive, it shows some schmutz in there, it doesn't necessarily mean that you're going to feel better after being scoped. But what it does is a negative. It's truly negative in there. It looks normal. They don't need to go in and clean out anything. It doesn't help at all to do that. So it is helpful for that. And if you're a jock in here, if you're a runner, and your shins are starting to really bug you when you're running, you can either have basically a stress fracture, or you may actually have just a stress injury where you actually don't have a fracture itself. It's an inflammatory change. MR is flat out better at differentiating one from the other, where you've actually gone on to a true stress fracture from being a jock runner person versus just the insertion sort of inflammation that can go with runners from the insertion in your anterior chamber. MR is better than bone scan. Bone scan will light up. It doesn't differentiate the two. MR is better. And it does change management a bit. They may actually, frankly, immobilize you rather than take you off running if you have a stress fracture. So it may actually help change the management if you want to run a lot and you're having shin pain. If it's just inflamed, you just rest a while. If it's truly stress fracture, they may actually immobilize you. All right, how about soft tissue foreign bodies? I love abstract number 33. What they did in abstract number 33 is they took fresh cadaver hands, they stuck a bunch of stuff in them, They stuck a little glass in them, gravel, plastic, dry wood, wet wood, just stuck stuff in them and then MR'd them. I have visions of somebody walking by the MR scanner, glancing in there. It'd be like a horror film. A bunch of hands kind of laid out all over the place, going in and out of the scanner. They wanted to see what you see on MR as far as soft tissue foreign bodies. It is very good at seeing glass. Excellent at glass. It's so-so for gravel, plastic, and dry wood. And if the wood was wet, had been like you would have somebody who got a big old honking piece of wood stuck in their hand yesterday, where it now has gotten absorbed all the sort of fluid from your hand, doesn't show at all, actually. That is a problem. So it is good for certain things, not for others. And I figure if it's metal, it'll just suck it right out of there. Metal foreign body, stick it in there, it'll just suck it right on out of there. We decided at Harbor, we're pan scanning everybody, right, as it is anyway. So our big joke for a while was that we would actually take the trauma patients and just run them right through our ambulance entrance, take them right through the scanner, have them scanned from head to toe, and then have them brought into the emergency department. Because that way we could not only identify all the injuries, but find where their weapons were as well as they come in. I think we should just MR them all, because then we'll just suck the weapons right off of them. We don't have to worry about them anymore, and that'd be done. It'd be nice. We had a shootout right outside our back door the other day. It's very disconcerting to be coming into a shift and hear pop, 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 pop. Okay, this isn't supposed to happen right in front of my office. Well, come on, people. It's kind of frustrating. Okay, last little bit I want to mention before we end is the syndrome of nephrogenic systemic fibrosis. You must know this exists. I'd never even heard of it before I put this lecture together, or before I was preparing for this little lecture dealie. And then I saw 2 cases in our ER. I'm sure I probably had seen it before, I just didn't recognize it. What this is, gadolinium is a non-iodinated contrast material. No iodine at all. When you inject it into someone, the way they get rid of it is they pee it out. Okay, it's renally excreted. That's how this stuff gets gotten rid of. The problem is, if you don't have adequate renal function, it has to go somewhere. And where it goes is your skin and your collagen. It deposits permanently in your skin and your collagen. What happens initially is you get these plaques. One of the 2 cases I saw, actually, she had this really weird skin plaque things. They were kind of grayish brown. They varied in size from small, for about half a centimeter, to, baseball size. She had pretty big stuff all over her body. Her face, her forearms, her legs, her torso, all over her body. Well, what these were depositions of gadolinium. What happens over time is your body it reacts locally to it by contracting, and they can end up wheelchair bound, which was the 2nd case I saw within the last couple of months of this. A woman who's wheelchair bound from contracture she's getting from this having deposited in her, basically her big ligaments and tendons, and contracting down. It's called nephrogenic systemic fibrosis. For you, if you have MR capability and you're ordering a gadolinium scan, you have to check renal function. And what you want to look at isn't the creatinine. You want to look at that calculated creatinine clearance that we're all getting now that comes out of your machines. You want that. And the magic number is 60. It's actually the magic number for iodinated contrast as well, but that's the magic number, is 60. If their GFR is less than 60, you shouldn't be giving this stuff. Okay, less than 30, you absolutely should not be giving this stuff. And this is different from the iodinated contrast. We tend to, if it's a full-on renal failure patient, they're dialysis dependent anyway. What do I care? Let's give them iodine. It'll circulate forever, but who cares? No big deal. This is different. Okay, this is absolutely contraindicated in the dialysis dependent patient. Okay, you do not give it to that patient population. What it means is if you're ordering this stuff, you have to check a creatinine clearance. If there's the guideline recommendation is if the creatinine clearance is less than 30, don't give it. If it's over 60, you're completely fine. If they're in the tweener zone of 30 to 60, what they recommend you do is if you absolutely must give it, that you dialyze them urgently thereafter. The problem is that most of those patients are not dialysis dependent. You will have to put in a Quinton cath or something to get them dialyzed. And your options are, I wouldn't give it if you can possibly avoid it, giving gadolinium that patient population. This is, of course, as we are in America, a lawsuit was filed against GE in March of this year for, it's Omniscan is their product. GE failed to adequately test this product in renal failure patients. So this has now gotten into the huge litigation arena. For you, just know, don't use it in renal failure patients. The other 2 patient populations to be concerned are the new renal transplant patients, which most of us wouldn't, some new kidney. So even if their creatinine's normal, don't use it. And hepatorenal patients, don't use it. They are at increased risk. Even if their renal function is considered over 60, it's not recommended to be given in that group either. So that's the deal. So if you have 24/7 access to these studies, you're given gadolinium for rule out PE or rule out DVT or whatever the reason you're ordering it, know you've got to have a creatinine clearance first. Okay, you're still stuck with that. And then to wrap up the MRI stuff is sort of some trivia that's thrown at the end there about things, sort of safety of MR in general. If you have a stent, okay, so you've had your 5 stents placed in the last couple of years, you are completely fine to be MR'd. It's not going to suck the stent out of you somehow. You're completely fine to get MR'd. Implantable devices such as pacemakers and AICDs, it's not recommended to actually MR those patients. And what's interesting is it doesn't seem to reset them, and there's not a lot of ferrous metal in them. But the problem is that they do shift a little and they get hot, so they can actually cause burns. The 2 most common injuries associated with MR, the most common patient injury is from metal-containing skin patches. Nicorette patches, nitro patches, skin patches. All skin patches have to come off. They have a little bit of metal in them, and they get a burn. Okay, it gets hot from being exposed to the magnet. They get a burn. The most common hospital employee injury that occurs from MR is trauma from flying vacuum cleaners. And I kid you not, this is real. It is in the patient safety data out there, the hospital safety data. Cleaning people after hours come in, vacuuming, vacuuming, vacuuming. But the magnet's on 24/7. It's just kind of, down a bit, but it's still on. And they come in and the vacuum thing gets sucked and they get like beaten to death with this vacuum that's getting kind of pulled around the room. So that's the most common of the employee injuries is from vacuum cleaners. And I'll tell you do you know what the most common actually thing to happen with MRs just in general? Is erasing your credit cards. Keep all magnetized cards away from an MR scanner. We had some guy, I was talking to a guy at the last conference. The day before his honeymoon, he was working, kind of was in the MR scanner with a patient, had his wallet with him, didn't even think about it, and then went to like Bali and went to use his credit cards. It was like, they'd been totally erased. He was in the middle of nowhere trying to get to have a honeymoon with no credit card. So keep your magnetized cards away. There's a couple other things in here if you're interested, but those are the sort of most interesting. And the pregnancy risk, which you bring up, is brought up at the end. The risks are unknown. It's relatively like a relative contraindication, blah, blah, blah. That's covering your hiney. Any questions on MR? It's kind of cool technology. It's kind of interesting. Yeah?
Are they developing another magnetic element with magnetic monopole to substitute for gadolinium?
I am not aware of them developing something other than gadolinium. I don't know, though.
Other candidates.
Yeah, I don't know. It'd be nice, but I don't know. I'm not aware. All right.